Welcome to Priority Traffic Podcast, a haven where heroes meet, not to speak of battles, but to strengthen the armor of mind and spirit. This is where you, the guardians of our community, come to refuel your inner strength and sharpen your resilience. Every day, you give your all to protect others, and this space is dedicated to you, offering reprieve, support, and strategies to survive the demands of your noble profession and thrive within it. In every episode, we unite to tackle what it means to be a firefighter beyond the fire ground, delving into the essence of personal wellness and professional endurance. We believe that we can forge a path forward toward a fulfilling and sustainable career through open dialogue, shared wisdom, and heartfelt encouragement. Together, we'll explore topics and tools to empower you to manage the heat that comes with the job and to emerge stronger. Join us as we champion your well-being and amplify the power of the community. Welcome to your turning point, where growth is the journey and excellence the destination. Good morning. Welcome back to Priority Traffic Podcast. Dr. Krakow is here with us today, and we're going to dig into sleep, PTSD, and sleep disorders, and maybe shed some light on the idea of sleep and how we as first responders can get a little bit more out of it, maybe learn something today. So, Dr. Krakow, thanks for joining us.
Happy to be here. Thank you.
So I'm going to just jump right in. You're a doctor of sleep medicine. Can you kind of give us a little introduction on your background and maybe a little bit of backstory about how you ended up being a doctor of sleep? Because sleep is such a profound topic to me.
Indeed, it is to all of us who are interested in our sleep. And surprisingly or not, there's a lot of people that are not interested in their sleep, and they should be. And maybe we can get a few of them to take it more seriously. I trained as an internist and practiced in emergency medicine for 10 years, so I was intricately involved with first responders, working in a level 1 trauma center for that decade. And that was back in the 1980s and 90s.
Okay.
And then I ended up getting involved in a research project treating people with chronic nightmares. And that eventually led to understanding the relationship between chronic nightmares and post-traumatic stress disorder, because that's one of the cardinal symptoms that people, particularly those who have more severe PTSD, they will have these disturbing dreams and nightmares. And many of them don't even recognize that that's part of PTSD. They just think they've got these bad dreams. They don't know what to do about them. They may not even be seeking help, which is unfortunate because there are treatments for nightmares. Anyway, once I went into the field of nightmare research, that opened up this whole window of, wait, there's something out there called sleep medicine. I'd never even heard of it. So this was 1990. And from then on, I went to all the sleep meetings. I ended up doing all the training to get a board certification in sleep medicine. I became a clinical sleep doctor, but even though I worked at sleep centers, opened up my own sleep center, our work, because I started in mental health, stayed with mental health. So my whole specialty has been treating sleep disorders in mental health patients, particularly PTSD. We've published more research data on the treatment of sleep problems in PTSD than any other research group. And my most recent book, Life-Saving Sleep, New Horizons in Mental Health Treatment, is the compilation of what is largely my life's work in helping people realize that there's so much you can do for sleep in PTSD without using a prescription pad.
Really? So when you talk about nightmares, can you kind of give us an idea of, like, maybe what is a nightmare? And I know we probably all had it. It's that disturbing thing that happens while we sleep that's frightful and uncomfortable. But can you kind of explain what's going on there?
Sure. For PTSD patients or people who wonder if they have, post-traumatic stress, whether they're formally diagnosed or not, there's a lot of things, as we call it, can go bump in the night. That's an old expression. They go bump in the night. Mm-hmm. And that's a category called parasomnia. The biggest one, of course, is nightmares. You have disturbing dreams, typically in REM sleep. Most of these bad dreams would occur more likely in the second half of sleep. However, in PTSD, there's a lot of research showing that people can have disturbing dreams at various points in the night, and it's not really clear what stage of sleep they may be in at that time. We also know that some PTSD patients are prone to something called sleep or night terrors, which is a different kind of event. Usually there's not like, there can be dream activity, but most people would never remember it. They wake up very startled. They may not even know they just woke up. They may scream and yell and then go right back to sleep. Those are also very disabling because they disrupt your sleep. And of course, if somebody else is in the room, if you've got a nightmare or a sleep terror, they obviously have their sleep disrupted and they get very scared watching these people.
Yeah, that would be quite the ordeal, especially if you're not sure or if it's the first time you've experienced that. That would be could be traumatic, I suppose.
Absolutely. Not only that, but the worst case, and it's not so rare, is that people with both nightmares or sleep terrors do thrash around in bed. And they can injure the person sleeping with them. They can injure themselves. They can fall out of bed. They can break bones. They can get scratches, bruises. These are all indications, by the way, if anybody has that kind of activity in their sleep, they unequivocally need to go to a sleep center. They have to get a sleep study. They've got to get that big hookup with all the EEG wires. They got to figure out what is going on in their sleep to cause that, because that is very abnormal.
Yeah, that sounds like a pretty abnormal way to rest. So real quick, before we get too far along, as I have plenty of questions, can you give our audience just a basic, 10,000 foot view of sleep and its importance and what starts to show up when we don't have it, and especially in a high-risk profession like firefighting?
Sure. So the big issue here, especially from 10, 30, or 100,000 feet, is that people don't understand that the sleep deprivation word that gets thrown around all the time, and like number of hours of sleep that gets thrown around, that's not where the money is. Sure, there are people who want more sleep. And sure, there are people burning the candle at both ends because they use Red Bull and high energy drinks, and they do that. So absolutely, there's a whole category of those individuals, and there's not much you can say to them because they're committed to that lifestyle for whatever reason. That's a deeper issue. Sure. But amongst that group and amongst a whole other set of people, there's what we call a sleep quality problem. And that's where the money is. And that's where people don't realize it. They keep hearing this, well, don't you have to get 8 hours of sleep? Don't you have to get 7 hours? Why do you keep, and it turns out that's wrong. It's useful information, but it's wrong in terms of saying, what is your problem? Your problem is almost always based on a concept called sleep fragmentation. So sleep is this thing that absolutely restores your mind and body at night. And it even has a system in it called the glymphatic system, which cleanses the brain of toxins and waste material during the night. Well, guess when that glymphatic system works best? During sleep and during deep sleep. Well, deep sleep means high quality restorative slumber. So when somebody has a sleep complaint, and I like to say this, even though it's a lot of words, a sleep complaint, a sleep issue, a sleep symptom, a sleep condition, I throw all those words out the window. Those words are useless. The correct word is a sleep disorder. There's something physiologically active in that person's EEG, their brain waves, that's messing up their sleep, and that has to be diagnosed and treated. And so why? Because the people who don't treat it end up with what? PTSD, memory problems, concentration problems, hypertension, cardiovascular disease, dementia, workplace accidents. Sleep is this amazing thing that can restore you mentally, physically, even spiritually, according to some, that if you don't really pay heed to it, if you don't respect it, you're going to pay the price. And there's many people when they're younger, certainly, believe, oh, well, I can just sleep when I'm dead.
Sure.
It's a very famous expression. Many people use it in many cultures. And it's probably not true. I don't actually think you sleep when you're dead.
Yeah. You probably, you won't wake
You
up,
got-
but
you
you're
got-
definitely not sleeping.
Yeah, you got a lot of stuff going on after you're dead, and I don't think it involves sleeping.
Yeah.
So in this life, you have an opportunity to make yourself, as I like to tell people, smarter, quicker, clearer thinking, better judgments, happier. All these great things happen for people who sleep well.
Okay.
And for those people suffering a mental health issue, what's so tragic and sad is how many people in the mental health profession are not telling their patients this. They're saying, okay, well, you have depression, anxiety, and PTSD. Here's the medications. Here's the psychotherapy. Oh, and by the way, these medications and this psychotherapy, maybe that'll help your sleep.
Sure.
And unfortunately, it doesn't help to sleep consistently. That's why sleep disorders medicine is so important for mental health.
When you were explaining this, you kind of, you caught me off guard when you labeled the order. You said sleep problems and then specifically PTSD. And the way the fire service, or personally for me, the way I always imagined it, it was PTSD and then sleep disorders. Can you kind of?
I just, I got to tell you this story. I was talking to a buddy of mine just this past weekend. He's a mental health professional.
Okay.
And I said, here's the experiment somebody's going to do one day. I don't know when it's going to be done. It's going to be done soon, though, because other people are already starting. There's about 10 research studies in the scientific literature that are already beginning to address this, and then another 20 or 30 more that are indirectly addressing, and I'll tell you what I'm getting at.
Okay.
Give me 100 PTSD patients, and I'm going to treat them for their nightmares, their insomnia, their sleep apnea, their restless legs and leg jerks, their circadian rhythm problems, and that's all I'm going to do. And I'm going to compare them to 100 PTSD patients who get medications or psychotherapy or exposure therapy, and we're going to compare who does better. And my money, biased as it is, my money is on the group that gets this full course of sleep treatment. And here's one of the reasons why I feel so strongly about it. It's that when I did all of these trainings a decade ago, I went around to multiple military bases in the United States. I went to Hawaii. I went to Germany. I also went to other places in Canada and in Israel. And I started meeting people who already knew about many of the innovations we had done for treating nightmares and treating insomnia.
Mm-hmm.
And you know what they were doing? They were taking their PTSD patients and starting treatment with nightmare treatment called imagery rehearsal therapy. They were taking a patient and starting a treatment called cognitive behavioral therapy for insomnia. And again, starting that. They weren't even going anywhere near the patient with psychotherapy or exposure therapy, and in some cases, not even medication. And they were amazed that by treating the nightmares and the insomnia first, all these patients were saying, gosh, I'm feeling so much better. Like, well, do I need something else or am I done? And then some of them were saying, okay, well, if you say I need more, fine. I'm motivated to try more now. So in other words, they found so much receptivity and so much benefit by targeting the sleep problems first. They were saying, no, this has to change. Mental health has to change. We can't keep saying to them, oh, you've got PTSD. Here's your PTSD treatment.
Right.
They were saying, no, we're going to look at your sleep stuff first. So that's motivated me to begin asking this question, because we had done research 25 years ago. We were the second study published 25 years ago that showed that if you treat somebody's PTSD with a CPAP machine, because most PTSD patients that report sleep problems have sleep apnea.
Okay.
We demonstrated 50% improvement in PTSD with that study. By the way,
Wow.
it wasn't a great scientific study. It was called a chart review study. But we
Okay.
demonstrated that. Another paper demonstrated that, somebody else up in Philadelphia. And since then, there's been several studies showing that PTSD symptoms do get better with nightmare treatment, insomnia treatment, CPAP treatment. So I have said for a long time, we could rename this condition post-traumatic sleep disorders, and it would
Yeah.
be quite valid for a large contingency of the people who are diagnosed with what is called, PTSD.
Wow. I that's a very unique way, and it sounds like it's been going this way for a while, but it's new, absolutely new to me. But to address a symptom or a disorder like PTSD just by targeting the sleep is amazing. And one thing that, from my experience in the fire service, is we have a shift schedule, right? So we work 24, we're off 48, and there's a variation of these schedules where you can work one day, be off a day, and alternate between work and off for 3 days, and then have 4 days off, and maybe you'll work 2 days in a row and have 4 days off. How do you see sleep disorders showing up in that disrupted cycle of work where you're on call for 24, and it seems like we take most of our calls after 10:30 at night, or at the nighttime when we need to be
Right.
sleeping, and
Right.
then we only have a really small amount of time to uh, I guess you would say recover, and specifically let's just say sleep, those sleep opportunity days where you're not at work.
Yeah, shift work is a big can of worms.
Okay.
We looked at this in different ways. Back in the 1990s, we made certain predictions. Other people are coming up with the same conclusion. Shift work is dangerous to health. There's no
Okay.
question about it. And shift work probably is a risk factor for leading to the development of physiological sleep disorders, namely sleep apnea. By working shift work, you probably increase your chances of developing sleep apnea, because sleep
Hmm.
apnea is not simply what's going on in your airway. It
Right.
may also have something to do with how fragmented your sleep is, because it turns out when your sleep is fragmented, and this possibly is the explanation for why so many PTSD patients have sleep apnea,
Mm-hmm.
when your sleep is fragmented, it interferes with your breathing. So sleep fragmentation
Wow.
itself makes your airway less stable, is the best way to describe it. The research we did showed that 80 to 90% of people with chronic PTSD and a complaint of sleep have sleep apnea or sleep disordered breathing. Many other people have lower numbers. They say 30%, 50%, 60%. Nonetheless, those are huge numbers. And
Yeah.
that's a lot higher than saying everybody has hypertension. I mean, these are very, very astronomical prevalence rates of a breathing disorder affecting these people. Everybody wants to know why.
Mm-hmm.
One theory is this sleep fragmentation theory, and of course, night shift work exacerbates that. And
Okay.
so, one of the things that we tell people, if you go into shift work and you're doing shift work for more than a year or two,
Mm-hmm.
you've got to get a sleep study. You've got to get that evaluated to find out, because those people can benefit tremendously if they have a sleep breathing condition. Well, then that means they can start using their PAP machine on the nights they're off. And in some cases, if they're allowed to sleep on 24-hour shifts, they may be able to get in some PAP time then as well. And all of that can be very valuable, with one caveat, and that is PAP therapy makes your sleep so deep and so much higher quality that when you come out of the sleep, it's much more like when you were young and you didn't always necessarily wake up ready to go, but you
Sure.
woke up and like, gosh, that was a really intense dream, or I was in deep sleep and gosh, I need a cup of coffee. I need something to get me going here because I still feel like I want to go back to sleep. That's how deep
Okay.
the sleep can be when you go into with a PAP machine.
Wow. So yeah, in the fire service, and it just recently, and I can only speak from my experience in my department, but there's there you can't there's probably a fire station in my city that you can go to or can't go to that doesn't have one person on a PAP machine sleeping, and
Right.
it's so common, and I wouldn't have guessed that sleep would have. Well, I could guess shift work would affect sleep, but not in the way that we're talking today with the increase in PTSD or however that goes. But my
Right. Well,
mind
there's
is
all
just
these. Yeah. I mean, there's all these
exploding.
factors that. Yeah. No, it should. It should. I mean, this is actually in a certain way new,
Mm-hmm.
meaning that most people are not talking about this.
Right.
Most people in mental health are not talking about this. Most people in sleep medicine are not talking about this. The people who talk about this the most are certain places in the military that were exposed to this problem of chronic nightmares about 15 years ago after
Okay.
the Iraq War. And that opened up a window of opportunity where suddenly it was like, oh, we need treatment for nightmares. Well, once that opened up that window, people began to realize, whoa, there is all this other stuff going on because the nightmares are just the tip of the iceberg. So there's that place. And then there's other people that have their own isolated areas. Just recently, back in December and January, I did 3 hour-and-a-half long weekly podcasts for mental health professionals in Israel because, of course, they're dealing with tremendous amounts of PTSD in the soldiers, the first responders, the population. And I talked to them about nightmares, about insomnia, and of course, the big one we just talked about earlier, sleep quality and
Mm-hmm.
sleep fragmentation. But that was all new to them. And so even though this stuff has been in the literature, not just for me, but many other researchers for decades, you know how things work in terms of the concept of tipping point. This
Mm-hmm.
still hasn't reached the mainstream media. This
Wow.
still has not reached into all kinds of places it needs to be so that the average mental health professional, average psychiatrist knows very little about what we're talking about. And so what do? They reach for a prescription pad
Mm-hmm.
or they offer psychotherapy. And that's the end of that as it relates to sleep.
So I am in a position in my department where I get to work with new fellas, ladies and gentlemen. But we have this influence on them, and previously, up until right now, this conversation I'm having with you, I would typically say, "Hey, welcome to the fire service. We're glad to have you. Do you have a therapist?" And I'm going to update that and
Mm.
consider saying, "Do you know how to get sleep? And are you going to go get a sleep study?" Because this is like it's really turning up everything upside down that I've understood to be true, obviously. So you're definitely changing my mind on some things. One question I did have for you is, at what point do we know we either need a CPAP or like when does that individual start saying, "Hey, I'm gonna take this serious and actually go get a sleep study"?
Right. Well, let me plug my book in a way because
Please do.
in life-saving sleep, I talk about the fact that in the current climate, it is not easy to get sleep studies. And it's also not easy to get high quality sleep studies.
Okay.
Nowadays, everything is this thing called home testing. And unfortunately, that has many drawbacks to it. For people with obvious conditions, it's just fine. But you're dealing with people that are a relatively younger population,
Mm-hmm.
which means that the chances of showing a sleep breathing disorder, let's say, could be much more subtle. The chances of missing the diagnosis of something like restless legs and leg jerks is higher because you can't find that on a home sleep study. You have to
Right.
demand to get a sleep study inside the sleep laboratory. So the way I wrote the book was to say, look, the way the world works, there's lots and lots of do-it-yourself stuff
Mm-hmm.
you can do for your own sleep. And so there's a section in there to treat your nightmares. There's a section in there to treat your insomnia. with respect to sleep disorder breathing, I have this whole section called early conservative treatment steps. And I say this because people listening to this get so confused about this idea that they just can't imagine that it's true. It's just so hard to digest that so many people could be suffering. They go, well, I don't snore. I say, guess what? Snoring is a useless symptom to evaluate sleep disorder breathing.
Wow.
Only the people that snore loudly is it helpful. There's tons of people that don't snore, tons, thousands, millions that don't snore have sleep disorder breathing. You know what they have? They wake up at night to pee. They have a dry mouth in the morning. They have a headache in the morning. They develop high blood pressure. They develop problems with concentration, memory, and fatigue. So when you hear all of that, you go, oh, well, they should just go to their primary care doctor and, they'll get diagnosed with depression, get some medications, then they'll get on a high blood pressure medication, and then we're done. No, we're not done, because most people don't know that sleep disorder breathing actually causes you to wake up at night to urinate. They don't realize it causes you to have high blood pressure. So this is a really, really big elephant in the room. And yet, having said all that, people still don't believe it. They go, no, there's just no way it could be that big. So what I say is try early conservative treatment. So for example, you'll love this. If a person goes to the drugstore and buys nasal saline rinses, cleans out their nose multiple times a day, gets it crystal clear, no rhinitis, no allergies, no congestion, no stuffiness, and they do that with nasal saline only, in 2 weeks, they're going to come back and say, this is really weird, but I'm sleeping better. Why? Because their nose works. I've got this whole free video on my website, barrykrakowmd.com. It's called The Nose Knows, N-O-S-E-K-N-O-W-S. And I go through all the things you have to know about your nose, that we normalize it. We're so used to breathing, we just normalize whatever we have. Well, it turns out most people have little bits of congestion here and there. And they've already documented in the research literature 20 years ago. Do you know what Flonase is, the steroid nasal inhaler?
Unfortunately, I have a horrible relationship with it, and I've gotten a lot better, but it's the only thing that works when I need it to.
Okay, well, we're going to talk about that because there's some better versions of it. The best version is called Sensimis. It's over the counter. It's like a Flonase. And the research literature already shows that if you use that treatment, nothing else, you actually reduce the severity of your sleep disordered breathing. Again, what did you do? You just treated your nose. So I tell people start with nasal strips on their nose, nasal dilators in their nose. I talk about everything they can do to overcome the congestion. Again, on my website, the free video series, a person does that. Most people will say, okay, I tried these steps, and you know what? I'm sleeping better. And now they're going to say, does this mean I have sleep disordered breathing? And the answer is yes. It means you have some degree of it. Isn't it wonderful? I've had people on nasal strips. They'll do it for a couple years. They go, no, I feel great. I don't need anything else. And that's okay, because that's moving them in the right direction. Yeah. Other people, 3 months later, go, wow, if this is giving me this kind of benefit, well, what would it be like to use a dental device or a PAP machine? Yeah. And so it really gets the curiosity going. And that's why I recommend this so highly, because unfortunately the climate in sleep medicine is not friendly. There's so many obstacles to care that make it difficult for a person to even get tested or properly tested or get the right equipment. But see, if you've gone and done early conservative treatment and you feel like, oh man, I want this, you're going to be so motivated that you're going to knock down all the barriers and go, no, I want to get a sleep test. I want to get my PAP machine. I want this, I want that. That's how it works when you've had a taste of something that is really beneficial for you.
So you probably obviously don't know this, but we're literally discussing me right now because I have gone my whole life with congestion. So I learned about Afrin, the steroid one that's probably horrible for us. That works.
Afrin is Afrin's not the steroid.
Okay, so Afrin for me, that's the one that worked. Flonase didn't work, but Afrin it works. So that being said, I even
let me interject.
Yeah,
So just a teaser here for people because you really got to hear this. This is so cool. When a person says Flonase didn't work, and then they had to go to Afrin, that means usually there's either something anatomically wrong with your nose, something that has to be evaluated by an ear, nose, and throat doctor, or more simply, there is a condition, again, very widely overlooked in many medical professional circles, called non-allergic rhinitis. That's non-allergic rhinitis. So everybody's heard of sneezing and itching and getting congested and spring and fall. That's allergic rhinitis. Most people don't know how sensitive the nose is, and it turns out sleep disordered breathing appears to make the nose even more sensitive. And you end up with this condition, non-allergic rhinitis, where all sorts of stimuli make you either have congestion, runny nose, or stuffiness, for which nasal steroids typically do not work that well.
Okay.
And so when somebody comes to us and says, oh yeah, I used Flonase and it didn't work, I say, oh, well, you may have just diagnosed yourself with non-allergic rhinitis, and then we recommend what's called the antihistamine nasal sprays, Astelin and Astepro. We recommend another spray called Atrovent. There's another over-the-counter spray that's been out just a few years called X-Clear, a xylitol nasal spray.
I have that
Some people say that will work for non-allergic rhinitis. And so
it works.
This is this tricky thing. In other words, with non-allergic rhinitis, you don't get to suddenly just say, okay, well, I'm going to take this pill and I'm done. You got to work a few weeks to figure out which nasal spray in particular is going to work because it's dealing with a noticeable sensitivity in your nose. And the people who find that combination and they do it, they go, wow, this is great. I'm breathing through my nose. And that means they're now ready to use a PAP machine. Why would I give somebody a PAP machine who's horribly congested all the time, which, by the way, is a risk factor for giving them a very bad sinus infection, pushing all that junk up into your airway because you never got rid of it beforehand?
Holy smokes. So, yeah, I've done Afrin, so I need a recommendation for Afrin, me personally, but I'm sure anybody listening could benefit. But, yeah, Afrin.
Afrin is the one that causes other problems. Most people do poorly with Afrin long term. Afrin has its use in short term, but you want to go down a different pathway for these different conditions that are affecting the nose. Afrin is rarely, I know one person, he's a friend of mine, he's a doctor, and he actually swears by Afrin. He uses it before he uses his PAP, and he's never gotten addicted to it. He's very fortunate. Many people become way too dependent on it, and then it produces what's called rebound congestion, and they eventually just have to get off of it. Otherwise, they're going to drive themselves crazy.
So I use it when I get that horrible congestion where literally I can close one nostril and not breathe out the other one at all.
Right.
So I've done that, but so I made my way into nasal dilators where I have and it holds my nose skin up and it doesn't collapse when I breathe. So that's made a huge difference. But now I'm considering getting tested for a PAP machine only because I really have that. I haven't been diagnosed, but that non-allergic rhinitis, that makes so much sense.
Right. And remember, again, you're a young person. You obviously, you're a firefighter, you're fit. So people are going to look at you and this happens in sleep apnea. Well, you couldn't have sleep apnea. Well, what do you mean I couldn't have sleep apnea? They think you have to be overweight, obese, because somehow that's the training, which is incredibly ignorant. The research has been out there for over 30 years that sleep apnea is in your airway. If you are overweight, you can make sleep apnea worse. But it is very rare that obesity causes sleep apnea. It only makes it worse. And so that means lots and lots of people, such as myself, slender frame, many people. In fact, I have argued previously that the majority of people in the world who have sleep apnea are in fact not overweight. They're people who have malformations such as a small jaw or something going on in their airway for whatever reasons, whether it's genetic, whether the way their throat and their facial structure develop. All of these things have so much more importance, and those people constitute a hidden epidemic of individuals who have sleep disordered breathing. But the caveat, and you'll read about it in my book, Life Saving Sleep, is there's a condition called upper airway resistance, which is a more subtle version of sleep apnea. And here's another barrier. Only maybe 1 out of 3 sleep centers in the United States, as one example, recognize that upper airway resistance needs to be diagnosed and treated. Many sleep centers go around and just say, oh, well, you don't have sleep apnea, you're done. We can't help you. But that's not true. They have to know how to measure these more subtle breathing events, which are incredibly common in younger people and in people who look like they're physically fit, people who shouldn't allegedly have these breathing conditions. And yet, if they've got sleep complaints, high blood pressure, waking up at night to pee, cognitive issues, memory, concentration, if they've got these things, they all get put into the basket. Oh, well, you've got PTSD, you've got depression, here's some medication. Okay, maybe. I'm not saying, by the way, anything negative about the use of psychotherapy and medications, because they do work for people and they're necessary for many people. But that doesn't mean that's the whole story. And the mistake that I think is being made, candidly, is there's way too much emphasis on the psychotherapy and the medications early on without taking into account what the heck is going on with a person's sleep.
So again, I'm not trying to make this specifically about me today, so I apologize in advance, but I literally had a double jaw surgery, upper and lower moved. So my upper palate actually got detached from my face and moved forward because my upper jaw was so undergrown, they said, when I was young. They said it didn't develop as much.
How old were you?
So they noticed it, I think, when I was like 8 or 10, maybe 12. I had the surgery when I was 18. I had the molars pre-removed. I had to make space, and I a pattern through my life. And you can ask my mom or my wife or my brother even. I've had trouble with this, that upper palate, nose, mouth region.
So this is a great time. It's good that this is personal. This is a great story, and you should write about it and publish, something on it, an article, whatever, because what you're talking about is, whether you know it or not, you had sleep apnea back then.
Yeah, and I bet maybe do.
You could, yes, and that's what's so remarkable here. So back then, somebody might have said, well, this is cosmetic, or somebody might have said, well, maybe you'll breathe better, or somebody might have said, well, if we do this, maybe you'll swallow better, maybe you'll grow.
So it was a chewing thing.
Yeah, all kinds of things would come up.
Yeah.
But if they had tested you at the time, high probability of finding a sleep breathing disorder. Well, fast forward, the average person who gets maxillomandibular advancement surgery, over time, still ends up with sleep breathing conditions. Not necessarily right away, but yours was how many years ago?
So I had this surgery when I was 18, and it was to correct I had an underbite, right? Where your lower jaw sticks out excessively.
How many years?
Probably 6 years. Once I went through puberty, it just started to
No, I mean, how many years ago was the surgery?
22. I'm 39 right now. It's 22, 23 years ago.
Yeah, so almost 20 years ago. And so what happens is you're already describing certain things. I don't know what the rest of your symptom complaints would be, but
Sure.
when you look into it and you ask yourself about your sleep, let me point out that our original research, which occurred in the 1990s, we were working with all these sexual assault survivors, women with chronic nightmares, all in the average age range of mid to late 30s, okay?
Mm-hmm.
And we discovered after we did the research showing that we had this nightmare treatment, again, it's in the book Life Saving Sleep, it's called imagery rehearsal therapy.
Yeah.
We discovered through the years, because we kept studying them in different ways for the next 5 to 10 years after that treatment protocol, we discovered that between 80 and 90% of 187 women in this protocol had signs and symptoms of sleep disordered breathing. We actually were able to test approximately 10% of them in a sleep lab or with home testing, and every single person we tested positive for a sleep breathing disorder. And so back then in the 90s, we were saying, oh, this is all coming together now. It's not just nightmares. It's insomnia, it's sleep disordered breathing. We call it the nightmare triad syndrome. It's three things. The nightmares are just the tip of the iceberg. It's the red flag waving very brightly that there's something else going on with your sleep. And so we knew that was the case. And so in your situation, a person says, well, I had that surgery. Fast forward, what do you look back on? Do you say that I had some insomnia over the years, I had some disturbing dreams? Or do you say, no, I'm vibrant, I'm energetic, I've got all the energy I need, So wherever you're in, or whether you're between all of that, yes, there's a chance many people after the MMA surgery later on start developing new signs and symptoms of sleep disorder breathing. It's not a definitive cure like to the end of time or something.
Sure. Yeah, I looking back, I can't say I ever had anything, but being in shift work and valuing my fitness, like 6 years ago, maybe even longer, when I found these nose dilators and I started paying attention to my sleep, is when I started to try to get more fit. But I couldn't breathe out of my nose for a long time of my life, and I make it a habit. I'm very, very conscious of it now, but to not be a mouth breather, if you will. And I know there's time and place for that. But what is it? What is a sleep disordered breathing? Sleep disordered breathing.
Mm-hmm.
What does that look like?
Correct.
When you're not asleep? How does that manifest in like fitness or just sitting around or being alive, not asleep?
If I'm understanding your question clearly, correctly, let me just say, sleep disordered breathing is the single most common cause of what we talked about at the top of the program, sleep fragmentation. If you keep having arousal activity in your brain, because instead of going into deeper sleep, you have a breathing event, then you wake up a little bit for 3 seconds, 10 seconds, 32 seconds. You don't remember any of that. You just go back to sleep. And then what do? You repeat it again, another breathing event. So sleep fragmentation, the single biggest cause is sleep disordered breathing. And in your age group, some of the things you're going to see are trips to the bathroom at night, memory problems, concentration, attention difficulties. You're at risk for workplace accidents. There's things about your consciousness that you're going to pick up on sooner or later if in fact you are developing a sleep breathing disorder. Things as simple as your reflexes will change. You'll suddenly notice that, oh, I went to pick up my keys and I dropped them. And you'll go, well, wait, why did that happen? Oh, am I getting older, or was I not paying attention? All of these little things start to show up when cognition is changing. And people, after they get treatment for sleep disordered breathing, literally say things like, oh yeah, I actually catch my keys now when they drop.
Doctor, I literally have told like 2 or 3 different people this exact thing. Hey, I can catch stuff now when I drop it. Like I'll knock something off a cupboard and I'll grab a glass, or I'll drop my keys and I've been telling people, I'm like, I don't know what's going on with me, but this is literally happening. So this is probably one of the most profound discussions I've ever had live, where it's
Well,
impacted me.
well, I'm so glad to hear that. But I'm curious to know whether that's partly because you're using nasal dilators. Because a nasal dilator is what we call an early conservative treatment for either sleep disordered breathing in general or possibly for upper airway resistance. And so that's why I'm so high on people trying it, because I've
Yeah.
had cases where somebody this is a funny case. Some person who was very skeptical showed me their watch and
Hmm.
said, "Oh, this is interesting. My wearable says I'm having all this not, this fragmented sleep. I'm having light sleep."
Yeah.
I said, "Okay, well, you could do a little experiment if you want. You could just put a nasal strip on one night." And the person said, "What's that going to do?" I said, "Okay, well, just try it." They put the
Right.
nasal strip on. They come back the next day. I happen to see this person. They go, "What was in that nasal strip?" I mean, not only did I sleep better, but I looked at my wearable,
Yeah, oh
and my
gosh.
wearable said that I got deeper sleep last night. That's magic. How could that happen? So these
Oh
things,
god.
with my PAP machine, with my own PAP machine, I still use a nasal strip
Yeah.
and a nasal dilator with my full face mask, because I actually noticed the difference doing all three.
Wow. So the oh gosh, I can't think of the name, but I will put it in the notes. And I just want to tell you about the nasal dilator that I wear. Is it you attach two magnets right on your nose, and then you have
I've
a
heard about that
rigid.
one. Right, right.
And I use that for motocross. I wear it for hockey. I wear it when I go for like a long run where I want to be calm and not
Great,
sprint.
great, great.
But I wear it at night, and I remember the first time I wore this at night at the fire department. I
Hmm.
think the next morning I was running around with it saying, guys, you need this. This is changing my life.
Yeah.
And I didn't know that I was doing something. I knew that I had an issue sleeping, and I
Right,
was
right, right,
like, I'm
right.
always trying to solve, and there's always room for growth in my life. So but that is literally one of the things that I found, and holy cow, I didn't think I was going to have this conversation today. Like,
Well,
guys
well,
out
may,
there, you
well,
gotta
maybe.
you gotta get this
Yeah,
book.
yeah. Please, please, that would be helpful. Give us a good review if you can. Um,
Absolutely.
the thing is, in your age group, we wonder whether you have the definitive treatment. You know what I mean? Like, you're doing all this stuff, clearly getting benefit. And we
Hmm.
always say in this field of sleep that the hardest thing to find is your ceiling. You like, how would you know what the best sleep is for you? You just
Right.
went from here to here. How would you ever have a
Yeah.
clue what's above that?
Right.
And I've struggled with that concept personally and professionally, because I try to explain to people it's very difficult to sort that out. I've gone through my own episodes where my sleep wasn't where I wanted it for, say, 6 months, and then one day I figure out, you know, this is something to do with the way my chin strap is actually placed on my head and causing an irritation, and it's not really doing the job it's supposed to do. Fix that, and then the next couple of weeks I go, well, that was it. And now I'm sleeping better with my PAP machine. This happens in sleep all the time. You just don't want to do anything other than to say, well, that must be normal. That must be
Right.
normal. And then you don't like think about, well, could it be a little bit better or not? And so you're going to have a very interesting journey, because you may end up getting a sleep study one day and
Yeah.
discovering that you do have continued sleep disorder breathing, or it'd be great if you got a sleep study with all your attachments, and they say to you, they say, no, you're sleeping great, your breathing's great.
Yeah.
That would be very, very interesting.
We're gonna have to, maybe we can cooperate and figure this out after we're done with this discussion. But I couldn't agree more. I am so curious now to understand and learn, and I think I might have just squeaked out a few more what I would call performance points. Right? Like, if I can sleep better, I can do everything better. I'm not kidding.
Yeah.
So I'm super excited about that. I was able to pull up the name of that nose dilator that I
Okay.
use, and it's the Intake Premier Nasal Dilator. It's a
Right.
non-invasive snoring solution,
Right. I've
and
heard
it
of it. I know one person who's also tried it and also reported some good benefit from it.
Yeah, and I even wore it under my SCBA mask a couple times at work,
Wow.
and so my correlation, all anecdotal, is the longer you can stay nose breathing, the calmer you can remain. As soon as you leave, right? I'm not sure what it is, but I've noted that's the correlation I've come along to.
So did you read James Nestor's book, Breathe?
I might have. I have several breathing books. I don't recall which exactly.
Well, I do recommend that one strongly. It's a very interesting book about breathing. Spends a lot of time talking about nasal breathing, just the way you said it. It came out about 4 or 5 years ago, James Nestor. And I just had finally a chance to read it just a couple months ago.
Well, I will find out if I have read it, and I will make sure that gets linked in the description for this podcast as well, right next to your book. And you have another book too, right? And if I recall.
Yeah. In fact, I don't know if we're getting here to close to the end, but I do want to point out a very important closing point, which is, I put up in my other larger book, Sound Sleep, Sound Mind, that came out about 16 years ago. I ended that book with a very cautionary tale. And I'll say it here because it's funny how you said the thing about, if you get a little bit more performance points and you can do everything better. Some people, unfortunately, when they sleep better, they have so much energy, they don't know what to do with it. And I know it sounds funny, but they actually get in trouble. I know. I know of cases of people. I don't want to go into a lot of details, but let's just say a person took that energy, used it in the wrong way. I'm not talking about violence. I'm talking about, doing something outside of relationships, doing something at work, being just. I don't want to. It's the equivalent would be saying, making somebody hypomanic, and that person not understanding that then colors your judgment about what you can do, because human beings unfortunately are innately greedy, and they want and they want and they want. Once you get back to normal sleep, it's a little bit scary. It was very scary for me in 1998 when I realized that I had been suffering a sleep disorder for 35 years, and I suddenly had all this energy. And it was like, what is this?
Yeah.
For 35 years prior, I wanted to take a nap every day.
I feel you, man.
Now, every single day, it was like, I still have more energy. Well, what am I going to do with it?
Right.
Do I need to sleep less, or what is going on? It's a very confusing picture. You would think, well, wouldn't it be great to sleep great? And yes, it is.
Oh man.
But it is a cautionary tale. There are some people who sleep really well. In fact, to show you how this plays out in mental health, it's well known that there are cases of people who are really bipolar.
Okay.
And they ended up getting their sleep apnea treated, and that's when they figured out they were bipolar.
Wow.
Before that, they just thought they were depressed. Somebody came along and said, oh, well, you're depressed, man, but let's check your sleep. So they check their sleep, say, whoa, you got bad sleep apnea. Treat their sleep apnea. They're not depressed anymore. Now they're manic. So they actually had a bipolar problem. And it's rare, but it's not so rare that it doesn't happen. It's been reported in the scientific literature a couple of times, and I've heard of cases of it. So there is something about our energy level that we don't really understand in this modern world, because so many of us do have sleep problems. And so we just resort to Red Bull and caffeine and other things. But once you get normal sleep, it's a very interesting experience to live with that. Very interesting. Especially the younger you are, to tap into that, it can make a huge difference in your long-term health.
You heard it first, guys. Tap into that. I did have a question for you before we do wrap up about your sleep coaching for high stress profession.
Great, great. Thanks. I'll go through all of the things that I do for my resources. So
Yeah.
on my website, barrykrakowmd.com, I have a sleep coaching service. It's
Mm-hmm.
not something that's covered by insurance. It's designed really for the person who usually has not made the progress they wanted working at another sleep center or working with other doctors where they said, I tried everything for my insomnia and nobody's been able to help me.
Right.
And they come to me and they say, can you help me build a roadmap to explain why the things I did previously didn't work and what are the things that would probably get me moving in the right direction? Many of those people end up, of course, getting a copy of the new book, Life Saving Sleep,
Mm-hmm.
because that actually allows them to refer back to it, over and over again. Because, coaching services can be a little pricey for some people.
Sure.
But
Sure.
nonetheless, in that 1 hour session or 90-minute session, the average individual comes away with, like, I've never heard any of this before. None of my sleep
Yeah.
doctors told me this. None of my psychiatrists told me this. And they go, this sounds like an incredible new pathway that I can go down to help myself sleep. So we have the sleep coaching service there. On that website, we also sell other books and
Great.
videos that talk about some of the same things we're talking about. And then there's another angle. I have a newer Substack newsletter. It's only been out
Okay.
a couple years. And I update it, a few times a month, sometimes weekly. Often I'll talk about some new research thing that came along that I have some concerns about how it's being interpreted because the
Mm-hmm.
journalists nowadays are very poor at really asking scientists hard questions about the data they're presenting. They're just looking for quotes. They put the quotes in the article and then you're done, as opposed to actually saying, well, can you tell me about why this could be wrong or why
Sure.
this could actually help somebody even though you showed it didn't? So it's a big problem in journalism today. They don't really, and that's why, of course, the world of Substack and podcasts and so forth is replacing a lot of that. People can get very much more accurate information by these kinds of programs. And I'm very pleased I had an opportunity to have this great conversation with you, Chris.
Yeah, it's been very enlightening to say the least, and it should, I don't, hopefully everybody else gets as much out of it as I have, because this has been a big one for me. But with all your experience with workshops going around the world, working at military bases and with veterans in the medical centers, what would you say is a good way for fire departments to start integrating sleep health into their preventative practices?
It's a tricky question because the first problem is they won't want to. In other words, there might
Okay.
be some people you'll meet that'll go, "Well, that sounds interesting," but it's not something that there has to be sort of a buy-in, and most of them will say, "Well, I don't see the buy-in." And you would say,
Right.
"Well, wait, but what about all this data about PTSD and workplace accidents?" So I just want to point out that when you try to do stuff like this,
Yeah.
it's not unusual to run up against a very large segment of professionals who go, "Oh, that's very interesting. Well, right now we've got this other project. Get back to me in 6 months." Of the
I get that a
people
lot.
who are, yeah, yeah. I mean, it's the way it is with so many things that are innovative. But sleep, remember, is very much disrespected. That's the
Okay.
biggest barrier. Sleep is a very disrespected human behavior. And
Okay.
so that already you have a strike against you. The second strike against you, of course, is the fact that the people, they're just not interested. They don't have the time. I think the thing that's most useful is if you get somebody's interest, you say, could we have a sleep doctor come and talk to the fire department? Or
All right.
can we have a sleep center have our firefighters come over to have a tour of the sleep center? Because it is a very interesting environment. And
Yeah.
unfortunately, firefighters and first responders actually show up at sleep centers once or twice a year to pick
Mm-hmm.
up a patient who is having a cardiac arrhythmia. And it does happen. So most firefighters are familiar with sleep centers for that particular reason. But that level of interaction is probably the first step. getting people to say, would you like to have some education? Because a lot of sleep doctors do like to do that. They do like to come out into the community and say, yeah, sure, let's have a discussion. And then, just like you said, some of those firefighters are going to go, oh, well, you're talking about me. Maybe I should come to your sleep center. And that doctor is going to say, oh, this is great. I came here. I got some more patients. So it works that way first before it works to integrate something into your sleep center. Once you start making a connection and more people are say they're interested, oh, Joe over here has a PAP and Sally's got a PAP. Now everybody's starting to talk about sleep. Now you can do something more internal. It's a lot easier when people have their own personal stake, because then they have something to offer. It's kind of like a 12-step program. Everybody's got something to offer because they've been through it. If you start in with people who know nothing about sleep, they're not going to necessarily want to sit around and talk about it.
That's a great idea, and I think I'm going to do that the next opportunity I get. This has been the most eye-opening episode I've ever recorded, personally, and hopefully the people listening, all of you guys out there, guys and gals, take something from this and just figure out how good you're sleeping. Figure that out. And what's a good way for someone to assess their own sleep? Like,
it's easy. They should wake up in the morning and feel great. Okay. If you don't wake up in the morning and feel great, there's always a window. It might take a few minutes to wake up and get out of bed. But if you don't feel great within the first 30 minutes, usually, maybe a few people it's an hour, without coffee, without caffeine, maybe a little bit of exercise, if you don't feel really good, then you should begin to wonder whether there's something going on with your sleep. Okay. That's simple.
Well, you guys heard it first. Do you feel great when you wake up? If not, it's time to take responsibility for your sleep and stop disrespecting it, as we've learned it is so often with our discussion with Dr. Krakow. Doctor, I really appreciate you making time. If you don't mind, real quick, just give us the name of the book again and the best place for people to get a hold of you, like your website.
Sure thing.
And then we're going to wrap it up today. But again, I can't tell you how grateful I am to have you made time for us today.
I'm so glad that I could be here. Let's just start with my Substack. My Substack newsletter is fastasleep.substack.com. My new book is Life Saving Sleep, and that's either at Amazon or wherever books are sold. You can also just put in lifesavingsleep.com.
I'll put a link in as well.
Right, thank you. And my main website is Barry Krakow, Krakow, barrykrakowmd.com. That has all has some past talks on it. Many of them are free to watch. There's also some videos and books for sale. That's also where you sign up for coaching appointments. Generally has most of my stuff there, and of course a way to contact me. There's a contact form on that website.
Excellent. Well, again, on behalf of the audience and myself, Doctor, thank you so much. Anybody out there looking to improve their wellness and take their performance to the next level, guys, we have to invest in our sleep. We have to understand how important it is. And to reiterate this entire discussion, we need to respect our sleep more. Doctor, thank you so much. It's been a pleasure. I hope you have a great day.
You're welcome. You too. Great to be with you.
That's a wrap on today's episode of Priority Traffic Podcast. Thank you for tuning in and for your commitment to growth, both in your life and in service to others. Remember, this community is here for you, offering support and strategies to help you thrive. Keep the conversation going by connecting with us online. Visit our website to access more resources, follow us on social media platforms for your daily dose of encouragement, and to share this podcast with your colleagues who might benefit from our collective journey towards wellness. Till next time, take the insights from today, let them guide you, and continue to prioritize your well-being, because you deserve to lead a fulfilling life on and off duty. Stay safe, stay well.